good afternoon, everyone. We are here once again with a very interesting topic about partial knee replacement, also called as unicompartmental knee replacement. I am Vaibhav. I am Dr. Vaibhav Bagaria. I am the Director of Orthopedics at the Sir H.N. Reliance Foundation Hospital in Mumbai. And it is my pleasure to welcome my mentor, Dr. Ashok Rajgopal, who is a pioneer in the field of knee replacement. He has been doing so many knee replacements even before I was born. So it's really a pleasure to welcome the mentor of my department, Dr. Ashok Rajgopal, with us. So I'll set the ball rolling by asking a very important question. We have so many things about knee replacement, और उसमें एक नई चीज है half knee replacement या partial knee replacement, also called as unicompartmental knee replacement. So my question to you is, sir, how do you decide कि किस patient को half knee replacement या partial knee replacement लगता है? Which are the right candidates for that? How do you decide on it? What should patient tell you, and how do you then ask the patient that you are the right person for partial knee replacement?
So good morning, Vaibhav. Always a pleasure to be chatting with you. A great question on a great subject. I think partial knee replacement is really evolved now as a frontline treatment option for patients who, like you very rightly said, there is a very select group of patients that lend themselves to this surgery. ये कहना I think legitimate होगा कि horses for courses, and if you take a patient who has involvement of only one part of the knee, घुटना हम लोग ऐसे as we know they are basically three compartments. The medial जो अंदर वाला हिस्सा होता है, lateral जो बाहर वाला होता है, and then the one in the front which is the patellofemoral, the one with the kneecap. So you can have selective arthritis which involves only one of these three components. And if you have these patients who come to us early enough in the disease process, you can selectively replace one of these three options, these three compartments. You can actually combine two compartments as well. You can do the patellofemoral along with the medial, or patellofemoral with the lateral, or the medial and lateral. So this is a selective treatment where the implant is addressing the area where the pathology lies the most. Like you rightly asked, there are very specific indications, and the longevity and the success of the surgery is selecting your candidates properly. They should not have rheumatoid arthritis. Obesity is a gray area, and सबसे ज़रूरी बात, like you I'm sure would agree, is this is not an operation for the occasional arthroplasty surgeon. You should be doing this often enough, and the results are very good.
It's a great thought, sir. So if I can just say what you said, one is it depends on how is the disease. अगर एक particular compartment में सीमित है, or if it is confined to one particular compartment, those are the people in which we can do a partial knee replacement. Sometimes when there are two compartments, we can do two selective compartments. That is there. Any age restrictions on this? आपको लगता है कि एक particular age group में इसको करना चाहिए?
So earlier it used to be said is the first knee for the young patient and the last knee for the elderly patient. I think that has gone away from that. In the younger patient, there are alternative options like osteotomies, where we realign by cutting the femur or the tibia. But typically, if you have what is called a bone-on-bone, where you have total loss of cartilage and you've taken a weight-bearing X-ray, you're able to correct that deformity, and your ligaments are intact, particularly the anterior cruciate ligament. Having said that, now there is a school of thought that anterior cruciate is not critically important. Even if you don't have it, you can still do this with good results, particularly in certain types of unicompartment treatment options. And they do really very, very well. So Vaibhav, my question to you is, you are this very bright brigade of orthopedic surgeons who's skillful in routine surgery, and we have so much of technology that is now available. So what are your thoughts about using technology in performing a partial knee replacement?
It's very interesting that you asked that. And you know that technology is impacting everything in our life. I think we cannot not use the word technology for phones, even if they are 5 minutes away, we feel fidgety. So I think technology will transform most of the things that we do in the orthopedics, in the arthroplasty, and even beyond that in our day-to-day life. But unicompartmental, I truly believe is the robotic was designed for a uni surgery. That's how it began. I think it's one of those surgeries where they have made the maximum impact on our ability to balance tissues better, to understand how the wear pattern is. And you rightly said that the UKRs are the surgery for not very occasional surgeons, but someone who has understood the concept of it. And I think what robotic does is put that understanding on a paper, on a screen. It tells you how the knee is and what you want to do with it. Like any technology, you have to be well versed with what you want from the technology. But certainly, I do believe that robotics, especially the handheld robotics in this aspect, has made a great stride, and I think is an important tool if you are deciding to do or take up unicompartmental knee replacements in a big way. So I think yes, I think technology will be there, and in future doing it without technology may sound a bit of not the right thing to be done for unis at least.
So a lot of patients, I'm sure they ask you, they ask me, I think they ask all arthroplasty surgeons, is partial knee replacement really a half knee replacement? So what is the difference in philosophy between a full and a partial knee replacement?
So yeah, so instinctive answer is yes, a partial knee replacement is indeed a half knee replacement. But if you look from the standpoint of technical ability, I think it is much more than a knee replacement, because you need to be much more well versed with the technical aspects.
Right.
If you look at the surgical complexity, yes, the ability to execute is much more. But at the same time, if you look at the damage created or the interference with the normal functioning, I think it's much less than half, because you are preserving your ligaments, you are not doing too much to the joint, so the recovery is much faster, even less than half the time in most cases, and it lasts not only half but much more than the half. So half is a paradigm. I think if you ask me in overall aspect, it is not truly a half knee replacement, but much more than that. What's your thought, sir? Or what do you think?
No, I totally agree. I think the one mistake that a lot of younger surgeons who are starting this procedure feel is that you reproduce the philosophy of a total knee, cut that in half and do it.
I think, yeah.
And I think that is where the mistakes start to happen, because this is really not a half knee replacement. You do not correct the deformity. You leave the knee in the same alignment that it is, what we call the pre-arthritic alignment. So you're absolutely correct. I think it's a change in the way you think in your mind. The other thing is, it is a more complex surgery, because in a total knee replacement you're actually opening the knee joint and doing it, whereas this is done through a very small incision, which is again a huge help when we use handheld robotics, because it's a question of a few millimeters, and with the various robotic instrumentation systems that are available, those platforms, it allows you to get that millimeter accuracy, and we're able to perform these to our satisfaction. Also, we have a general question. There is a concept or a belief in the minds of the average patient that this is something that lasts 4, 5, 6 years and then falls apart. So walk us through what your concepts are. What if a patient was to ask you, how long do these knees last, these partial knees? What kind of figures do we have in mind?
So, sir, I think you made it very clear that correct indication is the primary thing. So if selected well and done for right indication, they are almost as good as a total knee replacement. The reasons why they fail is, one, if you have not selected them properly. Number two, as you rightly said, if the complexity of the case is not understood by the surgeon and he tries to take it as a half knee replacement or mimic the philosophies of total knee to be uni. And third is, yes, there are reasons in which the knee does progress to arthritis on the other side, which is the lateral compartment and the patellofemoral compartment. So if you ask me what is the global average, I think yes, it's slightly lesser than a total knee replacement, but still not 4 or 5 years. It's somewhere between 12 to 18 years. A good total knee, 20 to 30 years. In brilliant people like you, maybe ages. Okay, but yes, I think they do last well if the patient is selected carefully, and probably it should be, as you rightly said, the last operation for most of the patients.
Yeah.
Okay, so I think that older thought process of half life, half surgery is not there. I think the key, you rightly pointed out, is right indication, right person to do it, and right understanding of the subject.
Yeah.
So if we do it well, I think we are enough for it. What?
I think you know, one point that I would like to sort of emphasize is robotics was really created for the partial, and you know, everything else we're doing beyond that is an extension of that philosophy. But this is absolutely a glove fit indication for the partial, because it gives you the precise cuts, it gives you the exact sort of planning that you have done, and technology, I would reiterate, that is absolutely a perfect match for a partial knee replacement.
But so as they say, a tool in the hand of fool is still a tool only. So a lot of good things about unis. Any bad thing, anything that you think that one should be careful for the patient, for the doctors, for the surgeons? How has been your overall experience? What are the bad sides of a uni? Do they fail? And when they fail, what do we do?
So again, to reiterate, right patient, right surgeon who is thinking right. So there has to be a lot of rights about this. The bandwidth for selection of these patients is very, very critical. It's very narrow. And well, you can compromise to some extent, but if you push the envelope, they're going to fail. Conventional partial surgeries, there are several risk factors. Fractures can happen. You have a mismatch in gap between your flexion gaps and extension gaps. You can oversize it, you can undersize it. But if you do these well, like you rightly said, they go on for 15, 17 years. If they fail, you've done it well, it lasts 14, 15, 16 years, and then it fails, the conversion from a partial to a total is not that challenging a surgery. Sometimes if you've taken the tibial cut a little deep, you might need to use some sort of an augment. Usually stems are required for these. But the overall post-operative results in the long term of a conversion from a failed unit to a total are almost similar to that of a primary total knee replacement. So
you're not burning any
You're not burning any bridges, and you're still, ensuring, like you rightly said, 20 to 30 year window after a total knee replacement. You're still able to re-establish that with confidence.
Great. I think we had a great conversation on this subject from someone who has done it and who has taught so many of us on this subject. And I'll just sum it up that partial knee replacement is a very good operation for people who have the right indication. It is important that you choose the right surgeon who has got enough experience with it. People who use technology for this particular operation, I think it's a great plus. And if need be, when we convert these partials to total, the results are not compromised. So you are not really burning the bridges. Of course, as we both reiterated, right indication, right people, and right place, right technology are all important. So you have to check a lot of right boxes to get the surgery right. And I know many of you may have a lot of more questions, so do feel free to type in the chat box there, and we'll try to answer them to best of our capabilities as soon as we can. So thank you, sir, once again. It's always a pleasure, even if it's a short conversation, lot of learning.
Thank you so much. Thank you.
Thank you.
Thank you so
Thank
much.
you, everyone.